This is a bony anatomy review of the shoulder. To start with shoulder bony anatomy, we're going to first discuss the shoulder girdle. As viewed superiorly to inferiorly, the shoulder girdle is actually an incomplete girdle. As it does not have any bony attachment in the posterior aspect of the body. The shoulder girdle is made up of the scapula, the clavicle, and the sternum. Beginning with the sternum, if we look at the anterior aspect of it, I'll zoom in here for you. The sternum, of course, is the attachment site for our ribs as well as our clavicles. There are several bony landmarks to make note of on the sternum. First of which is the manubrium, which is the large superior end of the sternum. This is what articulates with the clavicles at the sternoclavicular joint. Just below that, sort of right along the inferior red line here, is a little ridge on the sternum. This is called the sternal angle. You can likely palpate this on yourself. This is where the bone takes a little bit more of an inferior run, and where we see the delineation between the manubrium and the body of the sternum, here highlighted in yellow. The body of the sternum is important because laterally on the sternum we have small facets for the ribs. So these are actually facets for the costal cartilage of ribs 1 through 7. And then lastly on the sternum, we have the xiphoid process, which is the very inferior tip of the sternum. If we pull a clavicle back in, this being the left clavicle, what you'll notice about the clavicle is that it has somewhat of an S curve to it. When looking at the clavicles anteriorly, as we are here, you'll notice that the medial or sternal end of the clavicle is slightly convex, whereas the acromion end or lateral end of the clavicle tends to take on more of a concave appearance. Okay? You can see that when looking at it from a superior view. Again, the medial sternal end has convexity to it. The lateral acromial end has a concavity to it. If we remove the sternum and just look at the clavicle itself floating out here in space, one thing to also note of is that the sternal end is very round and broad, whereas if we look at the acromial end laterally, you notice that it's a lot more flattened. You can certainly palpate this on yourself. This just helps from an orientation standpoint. If for whatever reason you were to find yourself with a lone clavicle sitting on a table and you wanted to know, gee, is this a right or a left clavicle? That will help with your orientation. Lastly, it's a little hard to see on this clavicle, but on the posterior aspect of the lateral end of the clavicle, or the acromion end, you actually have a little tubercle that sits posteriorly and inferiorly here. And we'll try to see that on another clavicle in a minute. This is the conoid tubercle, which is an important attachment site for one of our coricoclavicular ligaments, known as the conoid. So if we bring in the scapula as well as the humerus, you can see here on this lateral end of the clavicle that conoid tubercle in a little bit more detail here on the inferior and posterior aspects of the lateral or acromial end of the clavicle. So this is obviously a left shoulder. If we look at one of the last components of the incomplete shoulder girdle, which is the scapula, so we'll remove everything else except for the scapula. So again, this is a left scapula. We're currently looking at the anterior aspect of the scapula. And the scapula is a fascinating bone because it technically doesn't have any true articulation with the rib cage. It more or less floats over the rib cage and really assists with our glenohumeral rhythm to ensure that we have full range of motion within the shoulder. So looking at the anterior aspect of the scapula, there are several landmarks to make note of, which are palpable. These are going to be our inferior angle of the scapula, as well as the superior angle of the scapula. We also have the lateral border of the scapula and the medial border of the scapula. Anteriorly, you'll also be able to palpate the large projection that is shaped like a beak. This is the coracoid process, which is typically going to be found if you palpate out to the lateral 2/3 of the clavicle and then go inferiorly 1 or 2 finger widths from the clavicle, you're likely to find that coracoid process. This bony landmark serves to as an attachment site for several muscles, which we'll talk about in the musculature review. Other landmark to make note of here, it's not palpable, but the large flat surface on the anterior aspect of the scapula, this is known as the subscapular fossa, which of course is an attachment site for subscapularis in particular. Serratus anterior also attaches onto the fossa. Towards the superior margin of the subscapular fossa, you'll notice that there is a small indentation in the bone seen here. This is the suprascapular notch. This is an important bony landmark because of in particular, the suprascapular nerve and artery that run through here. Looking at the posterior aspect of the scapula, as seen here, again, we can see some of our general landmarks of the scapula, including the inferior angle and the superior angle, as well as the medial border and the lateral border. But we see some additional specific bony landmarks that are clinically relevant, including the large spine of the scapula, which is a very easy bony landmark to get yourself oriented to the scapula and where you are on the body. Laterally, the scapula continues as the large flat acromion process, as circled there. And what's interesting about the acromion is actually its shape. So if we look at the scapula from a lateral view here, you can actually see the curvature of this acromion process. Okay? It has that slight curve to it. This is going to be classified as a type 2 acromion process, which is gently curved. And you're typically going to find this in about 43% of the population. It's the most common. What can happen pathologically of note is that the acromion process can actually take on a flattened look, so a straight line. This is going to be a flat undersurface with no curve. It's pretty uncommon. But what you're most likely to see along with that type 2 gentle curve is what would be considered a type 3 or hooked, which is going to take on a much more sharp curve to it. This occurs in about 40% of the population, and this sharply hooked acromion process is going to cause a lot of problems in terms of subacromial impingement and rotator cuff tendinopathy because we're impinging on that subacromial space. Lastly, for those anatomy geeks out there, you can have one other type of acromion, which is called an os acromiale. This is actually when the acromion does not fuse to the spine of the scapula. Looking back at the posterior aspect of the scapula, a couple of other landmarks to make note of here are going to be superior to the spine of the scapula. The broad, flat surface of the scapula is known as the suprascapular fossa. And then below the spine of the scapula, or infra, is going to be the infraspinous fossa. These two fossas are, of course, important bony landmarks for the attachment sites of the supraspinatus and infraspinatus muscles appropriately. Lastly, on the scapula, if we look at it from that lateral view again, similar to how we viewed the shapes of the acromion, you'll notice that there are one or two other additional landmarks to make note of. The first is going to be the articulation between the scapula and the humerus, this large flat surface here. This is known as the glenoid fossa. Above and below the glenoid fossa, we have two small tubercles that are important landmarks for muscle attachments, as well as labral attachments. The first is going to be the infraglenoid tubercle. This is where the long head of the triceps brachii attaches. And then lastly, if we tilt up just a little bit, there's a small ridge just above the glenoid fossa. This is known as the supraglenoid tubercle. This is an important landmark because of where the labrum attaches, as well as the short head of the biceps brachii.